Please click the like and subscribe buttons so that you can receive more of MAP's clinical pearls and technique videos.
Hey, this is Travis Stoner with Maitland Australian Physiotherapy Seminars. Today we're going to go through a little bit of a cervicogenic headache assessment and treatment. So this is my volunteer. We have already done all of the appropriate testing for ligamentous stability, as well as vertebral basilar and internal carotid insufficiency. Make sure that you always do that with all of your cervical patients, especially if you're thinking about going into end range extension or rotation. Considering we try to assess that on every patient, we should really be doing that with every patient with cervical symptoms every single time they come in. It's quick, it's easy, and it's a good screen to do to make sure that you're going to rule out any sinister pathology. So Ashley here has been complaining about right-sided headaches that tend to emanate from her neck and come up in kind of like a ram's word position on the right side of her head. A very good test, we did all the rest of the screening, but a very good test for that to rule in cervicogenic headaches is the upper cervical flexion rotation test. What you're looking for in this test is a lack of rotation from the upper cervical spine when you are putting their patient into full flexion. The side that is most hypomobile and or is reproducing their headache is the symptomatic side, and they could benefit from mobilization or manipulation. In this case, if she does test positive, I'm going to show you the upper cervical manipulation. So to do the upper cervical flexion rotation test, you want to get the hands around the base of the occiput, cup the occiput, and take the patient into full flexion. From here, you are going to then rotate the patient as far as you can in one direction. Remember that you shouldn't really be getting more than 45 to 50 degrees of upper cervical rotation because that's the limit at C1, C2. You will then rotate them the other way. And if you'll notice, she is very restricted going into left rotation. Did that start to reproduce some of your headache?
Yes.
So, from here, we are going to go ahead and do an upper cervical rotation manipulation. So I'm going to be getting my thrusting knuckle right about the occiput C1 facet. So I'm going to cup the occiput. I'm going to find her occiput C1 junction, which is typically about 3 finger breadths of the patient's hand away from the spinous process or occipital protuberance, however you want to classify that. Start feeling around in there and find the joint, and then you're going to put the thrusting knuckle right into that position. Our other hand, I'm just going to drop this down behind you. Your other hand then is going to be using the chin cradle grip. Whenever you're doing an upper cervical manipulation or any manipulation, you always want to take them to the end range and assess. I always ask about dizziness, lightheadedness, is it reproducing their symptoms? So I'm going to rotate her a little bit, just get her nice and loose. Here's my pre-manipulative position. How you doing with that? You doing okay?
Yep.
That didn't cause any dizziness, lightheaded?
No.
Doing okay with everything?
Mm-hmm.
Good. Did you see Ben Roethlisberger's beard, by the way? So, you notice I distracted her real quick so that she would kind of relax. That I tend to do that with a lot of my patients. She already consented to all of this. Make sure that your patients are consenting to it so that you don't surprise them with a quick manip. But I always like to distract my patients because if it's a lot of times, especially from us physical therapists, patients don't necessarily relax when we're going to be doing a cervical manipulation. So you'll get to that end range, and if you start to reproduce their symptoms, when you back out, they'll start to guard. So when I back out, and I'll kind of like get loosey-goosey with them a little bit, I always will say something to kind of distract them, make them think about something else entirely, and that's when I'll go in and do the manip. She did get an audible when I did the left upper cervical rotational manip, Remember that an audible does not necessarily mean that you did a high velocity, low amplitude thrust beyond end range. She did get the audible with her grade 5. Now I'm going to reassess her upper cervical flexion rotation test. And you can see she is getting a lot more upper cervical rotation to the left. And you'll always want to reassess, make sure, okay, how are you doing now? How's the headache? Is your neck feeling all right? Mm-hmm. So then go back and assess your active and passive physiologicals that made you want to go down upper cervical flexion rotation test and possible manipulation street in the first place.